We both studied under Caribou supervision, and we directly got together in this, okay, we have like a mission for evidence-based physical therapy in women's health and diastasis.
And when they do the sit-ups, the distance actually decreases, which is exactly opposite than what international and national guidelines say. If you contract the pelvic floor, or if you contract the transversus abdominis, the interected distance increases.
Still today, people come to the clinic saying, well, I know I cannot do any exercise. I have to avoid moving that area. They still say it because they heard it somewhere.
We have been putting so much fear on them to move. So lots of these women are really, really scared of moving and doing exercise.
Exercises that we thought were harmful for diastasis. And then we found that the distance was quite smaller. What we also can be doing at the same time is putting some fear on doing exercise.
So we really need to get these pregnant women moving. Enjoy the feeling of a body that actually works.
Today's guest is Dr. Nina Theodorsen. She's a physiotherapist and researcher based in Bergen, Norway, with a unique journey that started in political science. Her research focuses on diastasis recti, pregnancy, and postpartum exercise, challenging long-held clinical beliefs. She led a randomized controlled trial showing that specific 12-week core programs had minimal effect on abdominal separation, questioning restrictive guidelines. Her findings consistently show that many exercise restrictions are driven by fear, not evidence. We both studied under the legendary Professor Caribou, met 7 years ago in her lab, and have been research collaborators and close friends ever since. In this episode, we talk about what the data actually says about abdominal exercise, how clinicians can communicate risk without creating anxiety, and why movement should be a source of confidence, not fear. Welcome to Just Between Us and Science, the Women's Health Lab. I'm Patrícia Mota, physiotherapist, researcher, and professor. And in this podcast, we explore women's health through science, stories, and real experiences. If you are enjoying these conversations that bring science closer to real life, follow Just Between Us and Science wherever you listen to podcasts and share it with someone who might love it too. Today's guest, Dr. Nina Theodorsen, is reshaping how we think about the pregnant and postpartum body. Let's dive into this conversation. This episode is brought to you by Eleva Care, a digital platform redefining how women connect with physical therapy, obstetrics, and wellness experts. At Eleva, care goes beyond appointments. It's about support, guidance, and personalized health for every stage of a woman's life. Whether you're preparing for pregnancy, recovering from childbirth, or simply looking to feel stronger, Eleva Care helps you move, grow, and thrive. Visit eleva.care to learn more. Hello, Nina. Thank you so much for being here. I'm so happy and feel so privileged to have your presence here in this podcast for our new moms and clinicians and everyone that feels useful to hear us. So thank you so much for being here.
Thank you. Thank you so much for inviting me to let me talk about my research and also my clinical experience, because I also do clinical work. So I think the combination of the clinical work and research is really important.
Yes. So exactly along those lines, Nina, can you tell us about your journey into women's health? So how did you end up in pelvic and women's health physical therapy? And what inspired you to pregnancy and postpartum period? Tell us a bit, how did you end up in Bergen? A bit about your journey.
Yeah, I'm from Norway, and I live in Bergen, which is the second largest city in Norway. And I wanted to do studies in political science. So I went to Oslo and I started my degree in political science. And one of my flatmates, she did the same course as me, but she wanted to change over and do physiotherapy. So she applied physiotherapy in both the UK and in Norway. And she got a place both in Manchester in UK and in Bergen. And then I wanted to go to travel abroad, and my parents thought that that was a bit of waste of time. So then I thought, okay, if my friend accepts her place in Bergen, then there is one place in Manchester in the UK that is not taken. So I phoned the school and asked if I could have her place. And I hadn't applied or anything. And I have never sort of thought about what would happen if I became a physiotherapist. I didn't really know what a physiotherapist was. So, and they said, yes, come and have an interview. And 2 weeks later, I started physiotherapy in Manchester in the UK. So that's where my journey started.
Wow.
I had that you are supposed to have like an orthopedic placement and pediatric placement and a neurology placement. I never had an orthopedic placement. I had a women's health placement instead with a very inspiring, what do you call it when you like a tutor and supervisor.
Yes.
And she introduced me to the pelvic health area and women's health. And that was it. So I came back and I started working within neurology and rheumatology, but I soon moved over to women's health and pregnancy related exercise and pelvic girdle pain. And when you start off with pelvic girdle pain and women's health, the road is rather short to the pelvic floor, and it's also sort of a part of the whole area. So then I did some courses
Wow.
in both Norway and the UK on the pelvic floor and women's health. And of course, we've got like people like Kari Bø, who has been an inspiration the whole way. And we've got quite a few really good research in women's health and physiotherapy in Norway. So to have that inspiration and to be able to attend courses and seminars with these researchers was very inspiring. So that was my journey into the women's health.
That's hilarious. I didn't know that, Nina. We have a personal connection, but I had no idea. I think it's hilarious. And now I'm thinking about my oldest daughter, Maria, that now she's planning on her journey to the university, and she has some clues, but not very strong clues. And I was just last night telling her, don't worry, you have time. And if you go to a way and decide maybe it's not the way, you change, and that's what's life. So that's hilarious. I didn't know political science was the first choice.
And you always learn. It's never a waste of time. You always learn something, no matter what you do, I think. And doing the political science, and I was, still are, or still is very into like women's health politics and policies, and how on a more just individual levels, but also on the systemic, like how what kind of women's health advocacy and policies there are out there, and how we can change the whole system so that women can improve their own health is really important. That's why I also got into the women's health group in the Norwegian Physiotherapy Association. And I was a leader of that group for 7 years. So I'm really in political aspect of women's health as well. So I think it's never a waste. Start something, and then you can change it along the way. That's no problem.
Yes, you will figure it out. I myself, I was convinced by a biology teacher in high school that biology could be a way, and she used to say to me, you have a profile of a researcher because you know how to make questions, definitely. And so I did, and I went to the biology course, and then I miss the human part of it, so I changed to physical therapy. But in that year, I met some of the most inspiring women, and we are best friends until today. So it's so funny to see. It's true. It's never a waste. And in the end, I'm a researcher. So my biology teacher, she was right. So political science and biology, yes. And Nina, this is like we are in a cafeteria, which is my favorite kind of podcast. But we both studied under Kari Bø supervision, and we met 7 years ago personally in her lab. And can you tell me about what do you remember about that time, and how this mentorship started and things like that? looking forward to hear you.
Yeah. Being supervised by Karibe is an amazing experience. And I am so lucky that she was my co-supervisor, both on my master's degree and the PhD project. She is very efficient, and she expects that your work is top notch. Nothing else is good enough. In the beginning, when you send your manuscript and suggestions to her, and if she doesn't agree, then it's just like no, and you soon get
Exactly.
to it. But it's a very I really prefer that way, because then we
Yes.
don't waste any time, and she's very she makes sure that you know the academic language and the academic way of doing things. So the quality is, I thought it was a very reassurance that she wanted to be my supervisor, because she would never let me send off something that is not good enough, which is quite inspiring. I met Kari when I was leader of the Norwegian Women's Health Group. So we started off on like a professional level, not as a student and supervisor, which it was quite interesting, because well, I did my training in the UK, and at that time we screened all the postpartum women for diastasis. And then I came back to Norway, and I started doing the pregnancy and postpartum exercise groups and classes. And I took my knowledge back from the UK and started screening all the women. And the women had never heard of this thing before, not even the midwives or the doctors that were attending these classes. They had never heard about the diastasis problem. So that was sort of introducing this gradually. And then I worked along side with sports physiotherapists, and they were training the athletes on quite a high competitor level in Norway. And I sort of used the exercises that they developed for their athletes. I used the same exercises on my pregnant women and postpartum women, just modified. And then it was that the saying was that you should not activate the rectus abdominis muscles, and the way to sort of close the gap was to do the transversus abdominis contractions and the pelvic floor contractions, which I did. But then one of my colleagues sort of questioned the anatomy, and is this really what's happening? Is it really closing when you do those exercises? So we started sort of discussing it, and then I started sort of questioning the whole thing, the whole idea and the concept of exercise and diastasis. And then I started talking to Kari, which was then the same time that she was supervising your PhD. And Kari was like, "Oh, you really have to get into this research on this area." So then I started my master's degree, basically because I wanted to give my patients and my customers a proper answer. Should they do the exercises of the abdominal muscles, or should they not do that? So that's how I sort of ended up starting the research with Kari on diastasis in 2014, I think. Yeah. I really have to tell this because then she was supervising and she was talking about this Portuguese researcher that was doing a PhD, and her name was Patrícia Mota. And when I was reading all your articles, and when you haven't met anyone yet, and I hadn't seen a photo of you, and you sort of image a person, and then I was going to meet you in person in Oslo, in Kari's lab. And I walked into the room and I was like, "Oh, where is Patrícia?" And I just couldn't locate her at all, because I had imaged this really sort of small, elderly Portuguese, a very sort of strict lady. And all I could see was this young, beautiful, pretty girl sitting waving. So it took a few minutes before I sort of was able to get my image, self-made image of who you were, to actually see. Yeah.
That
So
was
that was quite
hilarious.
a surprise. Yeah.
Yeah.
What
No, it's
amazing was that it was like this instant friendship when we met,
yes.
which I really appreciate.
Yes, we laughed already so much on this situation. And I remember you saying I had a scarf or something. I should wear a
You know
scarf.
the nice suits that you see, all these nice researchers when they go to the conferences, and then they've got this silk bow coming out of the suits.
Yeah. And it was nothing like that. I have to confess that for Portuguese, I'm very tall, but I feel so
You
normal
are.
in Norway.
No, I was looking at this. Where is the the little Portuguese lady?
Yes. So when I started meeting you all from like Kari students, and as you said, it was the exact same experience for me, and the privilege for being supervised by Kari is that yes, you will work hard, but then when she says it's good work, you should trust her. So that's really reassuring, and it brings you peace.
Yeah. She very rarely says this is good. What she says is, don't want to see this again.
Yes.
Okay, we're good.
You're good. You're in a good shape. I don't need to read this again. Is the exact message that you are hoping for, from her. And so I was going to meet you all, and I myself had that experience of being pushed, and so I was going to meet Kari's students. So I was thinking, where are the brilliant students? And it was funny because they were all my size and blonde. It was so nice. But with you, Nina, I have to confess that we had some hilarious situations on that meeting in the conference. And we directly got together in this, okay, we have like a mission for evidence-based physical therapy in women's health and diastasis. So it was really, really nice. And then, well, my brother back then, he lived in Bergen, you remember?
Yeah.
And then we ended up eating the best seafood ever at your place after we met 2 days before.
Yeah.
It was just the universe was very kind on that trip.
Yeah. It was.
I'm
It was
so
brilliant.
grateful.
Yeah.
Yes.
Yeah.
So nice. So in 2024, a randomized trial, you found that the 12-week program had a small effect on the abdominal separation. Could you explain this result in simple terms? Because I think it's going to be a bit what you were mentioning before that drove you to the diastasis field. We didn't know what should we recommend, and it was the exact same experience for me. We didn't know how to answer these women, do it or not do it, which exercise. Maybe you can explain a bit more on that.
Well, I was quite sort of intrigued by the fact that the advice to these pregnant women and postpartum women to not do the exercises which engage the rectus abdominis muscle was so strong. But when you went into the evidence, there were hardly any studies on the effect of this muscle and if it actually opened the diastasis or not, or increased the interected distance, as we say. So that's sort of why I wanted to do the studies on pregnant women. And with the RCT, we had like one group doing this 12-week exercise program, and then we had a group that did not do the exercises. So when we looked at were there any differences between the groups towards the end of the exercise program, we saw that there weren't a big sort of statistical difference between the groups, but in the exercise group, it looked as if maybe the distance could be like 1 millimeter more than for the group that did not do the exercises. But in the end, when you sort of compare the two groups and do the statistical analysis, the difference was so small that it's not significant, and it's definitely not clinically significant. So when these women do these exercises, it will not sort of increase the interected distance. Hence, we can then say that there is no difference between the groups, and we think that it's safe to do these exercises.
Yes. So going a bit backwards so that everyone can understand what's this RCT's design. So it's the kind of design you need to say if something is working or not working,
Yeah.
if it's having any effects on a group. So we actually randomize the sample, the subjects, and we are blind to which one belongs to where. And then we measure after a program comparing to some comparing to the group that didn't do the tested program. So it's the best way, and it's the only way to say in evidence-based philosophy and way of practice that something has or has not an effect on that. Going backwards, the thing of advising women to do exercise or not to do exercise during pregnancy is something that we actually, as you said, we didn't know anything. And it's funny because in the US, Jenny Bagwell used to tell me there is so much research on the knee, on cruciate ligaments injuries and recovery, but the proportion of pregnant women and injuries in the knee is so different. And the amount of studies is so different too. So concerning exercise, we didn't know what to say. And when we started to see that the effect that we expected on diastasis was not actually happening, so then it was really, really nice that you could do such a powerful design on the study to show what's happening. Because I don't know if you have the exact same experience, but when we put some concerns on what people are doing related to exercise in such a particular moment of life like pregnancy, what we also can be doing at the same time is putting some fear on doing exercise, so which is
Definitely.
very bad too. So in your study, it was really
No,
go
I
ahead.
think
Go ahead.
it's lots of these pregnant women are really afraid of moving. During my PhD, I started my PhD in 2020, and at that stage, 30% of all Norwegian pregnant women were either overweight or obese. And when I did my when I finished my PhD 4 years later, this had actually increased to 40% of all Norwegian pregnant women were obese or overweight. And we also know that less than 15% of all Norwegian pregnant women do not do exercise as the national guidelines suggest that you do. So we really need to get these pregnant women moving. But when we have been putting so much fear on them to move, and because they think that if they activate the rectus abdominis, then this diastasis will increase or actually appear. So lots of these women are really, really scared of moving and doing exercise. So I think this fear attitude that we keep telling these women that you shouldn't do this and you shouldn't do this, instead of saying, come on, you can do this. It's not dangerous. It's not going to cause anything, injury or increased interrectal distance. We need to get these women to feel safe in their own bodies and to make them move. And when we were planning this RCT, we didn't really know how the different abdominal exercises affected the interrectal distance in pregnant women. So we started off doing a cross-sectional study, which is looking at what happens at a specific moment in time. So what happens to the distance between the abdominal muscles when they do a sit-up? What happens when they do a pelvic floor contraction? And we measured that using ultrasound, very much inspired by your studies. And nobody had done this on pregnant women before. So we basically we had some ideas that what was happening, but we didn't know what was happening. And what we found was that if you contract the pelvic floor, or if you contract the transversus abdominis, or if you combine those two, the interrectal distance increases. Okay.
So the diastasis is bigger. It's worse.
Yes, it's worse. And when they do the sit-ups, the curl-ups, or the diagonal curl-ups, the distance actually decreases which is exactly opposite than what international and national guidelines say that these women should do. Okay?
Yes.
But the most
Yes.
interesting thing of this cross-sectional study is that when you combine these exercises, when you do the pelvic floor contraction, you do the transversus abdominis contraction, and you do the contraction of the rectus abdominis, nothing really happens to the interectidistance. And that is what usually happens when a pregnant woman is moving in the real world. And when this pregnant woman is doing exercise, she will include all abdominal muscles in the movement. And we saw that that does not change the interectidistance at all. So that's when we can say that it seems that if you do the rectus abdominis exercises or contractions, it will not increase the distance. But this was just like what happens at a specific time. What happens if you do these exercises again and again, like 4 times every week for 12 weeks? What happens then? Is it the same? So then we, based on the findings of this study, made this exercise program where we included exercises that activated all the different levels or all the different abdominal muscles together. The pregnant women did this for 12 weeks, 4 times every week. And that's when we found that if you compare this exercise group to the non-exercise group, there weren't any difference. So the results that we found in the cross-sectional study was also the same results as we found in the randomized controlled trial in the end. And then we did the third study, which was like a longitudinal cohort study where we take a group of pregnant women in the beginning of their pregnancy and we did measure their interectidistance, and we asked if they had any comorbidity or if we asked about height and if they had stretch marks and if they had vaginal deliveries or C-sections from before, etc., etc. We asked them lots of things in order to be able to answer the question, are there any sort of factors that early in pregnancy that can sort of predict or say anything about how big the distance is after or towards end of pregnancy? And the results there also supported the results from the 2 other studies that abdominal exercise before pregnancy and during pregnancy did not increase the interectidistance at the end. So we have now applied like 3 different types of methods to investigate the effect of exercises on the interectidistance in pregnant women, and they all sort of say that there is no, these exercises will not increase the interectidistance. So I think we can say that it's safe to do these exercises.
Yes, and Nina, I have to confess that when we started to see that pattern of exercises that we thought were harmful for several things, and among them diastasis, and then we found that the distance was quite smaller than the other ones that we thought that were more conservative and adequate for this population. And we were really surprised, and it was so hard to publish that. And then when you started doing your PhD, I was kind of expecting your results to confirm if what we had found was okay or not. you know? And when Kari was sending the first draft, I was, oh my God, they found the same. I'm so relieved. And I think so. It's not, well, we are big fans of each other. That's truth. But also several groups did exactly the same and found exactly the same. And we are not related. We have no personal relationship with groups in Australia. And so they found the same. And it was really, okay, we did it correctly. And what we assumed was dangerous, maybe it's not.
No.
And so maybe we should stop putting this fear in women so they can move without getting any worse on diastasis and then on pelvic floor muscle function and everything else. So it was it's really important because still today, I don't know if in Norway you have the same, but I'm also a clinician, and still today people come to the clinic saying, well, I know I cannot do any exercise on a specific strengthening exercise for abdominals, or I have to avoid moving that area. They still say it because they heard it somewhere. The social media is full of some messages that are not evidence-based, and they are creating problems where there are not. And it's so nice to have studies that show us what to think. And if maybe in some years we find different things, well, we will deal with that. For now, we should really maybe stop putting some avoidance on exercise for diastasis, because what we found until today is that it's safe and it's not going to be harmful for any of the situations that we studied. So it's a really powerful message, and it's
It
also
is.
one of the missions of this podcast to transfer this knowledge from the papers to the community as soon as possible, because in Portugal it's still a thing. I should not move because I have a diastasis. You should have a diastasis. You are pregnant.
Yes, and I think
So
there are two sort
it's
of main messages coming from my PhD. And the first message is that
Mhm,
it's not dangerous for women to do exercises that involves the rectus abdominis muscle, but
mhm,
it's not dangerous for a pregnant woman to do pelvic floor exercises or transversus abdominis contractions, because the
mhm,
increase in the distance is only like 1.5 or 1.7 millimeters. So it's the distances are so small that it's more important that
mhm,
these women exercise and strengthen their abdominals and their pelvic floor muscles so that their function improves. That's the main
mhm,
idea. But another thing is the words that we as researchers and clinicians use when we talk to these women, because we keep on using
mhm,
words as dangerous or increase, or just by calling the increased interected distance for a diastasis in pregnancy. I think we should sort of avoid that kind of language. I think we shouldn't talk about a diastasis as a diagnosis until probably 12 months postpartum. That's when we can sort of start
mhm,
saying to women, I think you have got a diastasis, because if you measure them 6 weeks postpartum, and then if you measure them again at 6 months postpartum or 12 months postpartum, things change, because there is a
mhm.
natural healing. And I don't think that certain exercises will enhance that healing um, in regards to the distance, more to the function and the
Mhm.
strength of the muscle, which I think is the most important thing.
Yes, definitely. And it's curious because your experience is similar to mine when I started my PhD on diastasis. No one knew anything about it, and people didn't care much. So it was hard to recruit sample because they would not send women to us based on diastasis. And now we have the exact opposite problem.
Mhm.
So we should
Yeah.
say, stop talking about diastasis in pregnancy and early postpartum as this is a big deal. Because even if people don't do any exercise, which is not something that we should recommend. People should
No.
move, avoid the
Yeah.
sofa as much as possible. But even if they don't, diastasis will decrease. So this is also something that we see in research, studies on very early postpartum saying we have the answer for diastasis. Well, that's not true, because even if people don't do anything, the natural healing will bring the
Yeah.
rectus together. So why are we trying to prove that something is so great for this moment when we already know that
Yeah.
there's this natural healing, and the answer for which exercise should we recommend should be based in evidence and not trends. And in social media, it's a nightmare
Yeah.
to see the amount of misinformation that this population is. every day about bring your feet level and your belly shape to pre-pregnancy. My goodness, it's hard.
And I also think that this comes from the social pressure on pregnant and postpartum women to regain their pre-pregnant body.
Mm-hmm.
But the body changes when you become a mother.
Yes.
It's one of the most beautiful things that happen, that the female body changes. And I think it's much more beautiful after pregnancy and birth, when they've got the curves and they've got their breasts increase and their bums increase and their abdomen gets like a bit. That's completely normal, and I think it's beautiful, and I think we should start using a different language when we talk about our bodies after birth and pregnancies, and accept the bodies, because I have so many patients coming to my clinic and they come to me and they say, look at me, look at my abdomen. It looks as if I'm pregnant, but I'm not. And it's because of my diastasis. And then we assess the diastasis and measure it with ultrasound, which is a very good and valid way of measuring it. And then they probably have like 1.8 centimeters of a diastasis, which basically is not a diastasis, it's normal.
Yes.
It's completely normal.
Yes.
So I think that the distance between these muscles have been blamed on lots of things that it's not, that we shouldn't blame it for. Because I think that when you're pregnant, you stretch the skin, you stretch the fat beneath the skin, you stretch the soft tissues you stretch the muscles, and you stretch the ligaments, and you stretch, but it's usually just the skin. Well, it's basically the skin and the muscles that has got the most sort of stretchy tissue. So they sort of go back to what it was before. But then I think the body remembers. So when you get pregnant again, you look more pregnant sooner, because the body has been expanded before and it knows what to do. So it just does it. So it's completely normal to change when you've had a baby. We should focus on the beautiful thing of being able to carry and produce another human being. That it comes with a cost, and I think that cost, it should not be a cause of concern for these women.
Exactly. It's a very nice perspective, and I think we should definitely go for it. Embrace the change. It's beautiful.
Yeah,
It's really,
it is.
really nice message, Nina. Yes. And it's completely opposite from what we normally hear. So it takes maybe some pressure from this moment of doing everything so well and being happy for everything that's happening in the life. And on the top of that, go back to your pre-pregnancy body. It should not be a goal.
No,
you should definitely be exercising and be fit.
Yeah.
That's very healthy. Being pressured to go back to your pre-body shape, maybe it's not healthy at all and it's not natural. So that's a very strong message. I like it.
Yeah, but I think it's very important. And also, as you say, that these women should be encouraged to do strengthening exercises. And I think that we, by telling these women not to do these abdominal exercises, we have made them sort of fearful of using their body. And I think the female body is made to produce another human being. And I find it very surprising that the body should sort of, when the body is doing the most natural thing in the world, that then you should avoid using one of the largest muscle areas in the body. It doesn't make sense. And I also think that we should remember that these pregnant women, their body is the same. And the muscles, they need the strength in the muscles to maintain good posture and to be able to carry the extra weight, and also to get back to a functional body after pregnancy. We need the muscle strength. And also, if you look at athletes, when they get injured, or when we know that they are going to do exercises or perform their sports that will or may inflict some injuries, we strengthen that area. But in pregnant women, we actually tell them don't do anything. We don't even try to make their bodies be able to function properly. And we should go out there and say, you should do the strengthening exercises of the whole body because your body really needs this extra strength at this time. So get these women moving and get them to do their pelvic floor exercises and their abdominal exercise and enjoy the feeling of a body that actually works.
Exactly. Yes, I think we should do a statement like that.
Yeah.
It will help so many people.
Yeah. Yeah,
So,
I think
Nina,
so.
yeah. So now that still we have so many information that it's not based on evidence saying that pregnant women should avoid this and that. These guidelines, do you think they should be updated?
Definitely. I think they should be. And I think that we should get together and try and make these or make some new international guidelines based on the research that is out there. But we definitely need more research on the women with a larger diastasis.
Yes.
But it's difficult to do that because there aren't that many of them. To do those studies, we need to go together different countries because we need
Mm-hmm.
a certain amount of these women and they're hard to find because there are
Mm-hmm.
not that many. But I
Mm-hmm.
also think it's really important to remember that, yes, this change is natural and a part of the whole thing of being pregnant and producing another human being. But we should also remember that the abdomen is an intimate zone or area of the body, sort of at the same level as breasts and the pelvic floor. And
Mm-hmm.
many of these women who have a diastasis, their abdomen changes in aesthetics and how it looks.
Mm-hmm.
And this is also, we should, even though we know that it's not dangerous to do exercises and all that now, we have to remember to listen to these women because their changes, how this change affect how they look at their own body and self-image and their relationship to their own body and also their relationship to their partner, for example, might sort of be not as good if they've got a big diastasis or if they've got lots of changes. So we need to acknowledge the fact that this will make or have some implications on these women and they should have the support that they need, and also that we should meet them with a certain amount of understanding and listen to their worries and then try through exercises and to improve their function. And in that way, hopefully they will sort of start accepting their body in a different way. So, but I think it's really important that we also acknowledge that there is another dimension to this issue, and it's not just the distance of the gap, but it does affect these women with how they look.
Yes, definitely. And especially as you said, the larger ones, the larger diastasis ones, then it's also very powerful message to acknowledge that this interferes with the body image, the way they feel. So it has so many other implications that we should, as clinicians and women's health professionals, to listen to them and try to help them the best way and based on what.
And I also think that we should do research we should agree on when is a interected distance a diastasis. Is it the 2.8 centimeters or is it the 1.6? Or maybe it's 3.5 after you've had a child? Because I think that the measures that we operate with today is probably they're too small. I think that they should probably, I think it's normal to have a distance for or about 3.5 centimeters after you've had a child. I think that's normal. When you get
Yes.
or a larger number of of postpartum women, you see that this
Mhm.
is where most women are. So we need to
Mhm.
do stuff. We need to agree on when is a diastasis.
Yes, definitely. Okay, Nina. Okay, so along those lines, there is still a lot of information on different exercises that we can recommend. And in 2023, we co-authored a commentary on a journal about hypopressive exercises. And I wanted to hear you on, we collaborate on this commentary with others, making some important questions on that paper. So I wanted to hear you on what was the main message that you wanted to share with clinicians and new moms about, for example, this subject and this how this collaboration ended up being a letter to the editor on some papers like the one we did in 2023.
Yeah, I think it's very good to see that there is an increase in research on diastasis coming along, and the amount of studies that have been published on diastasis and exercise and effect of exercise has increased, which is good. But it's very important that we produce research and do studies that are of a high quality, because it's easy to make small studies with cross-sectional methods, and it's easier to produce those studies than to do an RCT. We need these studies, but we also need to know that they come with some limitations. We cannot sort of change the way of thinking about anything basically just based on the smaller cross-sectional studies. We need the larger RCTs and the systematic reviews. And some of the studies that are coming, like the ones on hypopressive exercise and the effect on diastasis, the quality of the studies and how they measure and how they measure the interactive distance, or how they sort of how these studies are done, sort of limits the ability to say anything about the effect of the exercises. I personally don't have anything against the hyperpressive exercises. They might be really good, but if we are to do research, we should do proper research of high quality, because what clinicians do is that they see this study and most clinicians don't have the time or the knowledge to evaluate the quality of a study, and they usually just read the conclusion or the abstract or the title. And if that says that, okay, you shouldn't do these exercises because that will increase the distance, and if that supports their way of clinical practice, it's very easy for them to accept that as a fact. But then when you go and assess the studies and the quality of the studies, and when you then see that it limits the ability to draw the strong conclusions, that kind of studies we don't need, because they will just make all the clinicians out there more confused, and these women will be more confused, because when researchers say that these studies show this and these studies shows that, clinicians and pregnant women out there usually don't know if these studies are of high quality or not. So that's when we wrote that paper and the report on that one study that was published. That's basically what we wanted to sort of say, that this is not good evidence-based research.
Yes. And it's my experience is exactly that. So the clinicians and the students and general population, they are not going deep in the methods of a study. If it's published, many students still believe if it's published, it's true.
Yeah.
So it's normal. It's not normal. It should not be done, but it's very common to confuse a statement in social media with a conclusion with an RCT, which takes, let's say, 4 years to do. I don't know. It's very different knowledge involved. But if it's published and written in a way that you kind of believe what's the conclusion there. And on that commentary, it was here in Portugal, hypopressive used to be very common strategy to offer to pregnant and postpartum women. So when that paper came out, it was like, so now we should be doing that.
Yeah.
Well, we actually don't know, and it's
No.
based on such a limited paper. You cannot say it, but the way it's written, then you have like an obligation to comment on that, like calm down with the conclusions that are not supported in this methodology, and it's not true. And they actually agreed with us.
Yeah.
So I agree with you when you say it's such an important population to study. So we definitely should invest in studies on that. But we should be cautious when we recommend exercises based on studies with methodology that does not support such an ambitious conclusions. So I would not recommend anyone to base their practice on conclusions of studies that are very limited, as that one was.
Yeah.
So yeah, it's still a debate. It's still, I think it's a positive one because people get together and talk and discuss ideas from the clinics. But I always provoke the clinicians because I think I can, because I'm a clinician too. And of course, I think I'm the best because my patients, I remember the patients that come back and say, Patrícia, you are the best. Merry Christmas. Here's some chocolates. I remember those. I don't remember the ones that mysteriously disappear and never came back because it didn't work. So, of course, we are biased on our vision as ourselves in clinic. So, if you are doing something for 40 years in your career and you read a conclusion of a very limited study that supports what you're doing, of course you will say, okay, I'm on the right way. We should all be doing this, which is not true. So it takes a lot of work to reply to editors making those commentaries, but I think it's worth it.
It's very important. Yeah. And I think it's also, as researchers, we have this obligation to actually ensure that the published research is of a high quality, and that and if there is research that is not of that high quality, then we should be able to say that these conclusions are limited, and that should sort of be on the front page, not sort of one sentence at the back hiding somewhere.
Exactly.
Yeah, I think it's very important. And also here in Norway, hyperpressive exercises is usually something that you have to do private. You have to go to a private clinic. So these women pay thousands and thousands and thousands of Norwegian kroners to get these exercise programs, and sometimes they're not even based on clinical assessment. So I think it's sort of fooling these women to pay lots of money for something that we don't have any evidence is better than something else. It might prove that in 10 years' time, hyperpressive exercises is the best. But show me the high quality studies, and I will be the first one in the line to sign up to learn how to do a hyperpressive exercise.
Yes, it's the same here. So the courses are extremely expensive. What I tell my students to do when they decide what to invest their money in advanced training is just go on PubMed and go do a quick search and see if it's worth it. If it's not based on any evidence, then you should decide with the knowledge that you are going to do something that you decided, but it's maybe not yet proven any benefit. And it's the same with patients here. They pay a lot of money, and to do it, it's so hard. You need to have someone with you. So you are not empowering people to train and do exercise. You are telling them you need to come to me to train and do this very complicated with breathing in a non-functional way and pay. So it's sometimes a bit confusing if we are inventing patients or if we are actually empowering them to have a better outcome out of the exercise. So It's really important to have this clear message. Nina, and as you are also a clinician in Bergen, in your clinic, can you tell me how this experience of being a clinician shapes your doubts and your questions for doing research?
I think I think you get the best research questions if you ask the people that this concerns. So in this case, it's the pregnant women coming into my clinic and their fear of moving and their fear of inflicting a diastasis upon themselves if they were to follow the advice and the guidelines that are actually out there. So that sort of shaped my questions, and I wanted to investigate, is it actually true that the interrectal distance increases when you do normal movement and normal exercise, like involving the rectus abdominis? So I think it's very important to have some clinical experience as well when you do research.
Yes, I agree.
Good. Yeah.
And and besides diastasis, are there any other topics that drives you or passionates you for maybe doing new studies?
Yes, I really want to do studies on the large diastasis, but might be a bit problem to get funding for that. Another big issue is the pelvic girdle pain and pregnancy. If there is any exercise that they should do that can improve their quality of health. In Norway, 50% of all pregnant women report pelvic girdle pain or low back pain during pregnancy, and musculoskeletal problems like this is very often causing the sick leave. And in order to keep these women working throughout their pregnancy, we need to investigate further what can we do to improve their function. So I really want to get into research of effect of exercise and physiotherapy for pregnancy-related pelvic girdle pain. I'm planning a proposal to get the funding, so hopefully we can do that together.
Perfect. Yes, I would love that. Great. And so for our listeners, Nina, and women, physical therapists, pregnant and postpartum women, anyone that is listening right now, what would you tell a pregnant woman that is worried about her abdominal separation? And what advice would you give to clinicians on treating diastasis recti?
To the pregnant women, it's not dangerous to move. Just do your exercises. And if you are unsure and if you don't feel safe, get in contact with a women's health physiotherapist who has knowledge about diastasis and can assess the diastasis for you. And they will be able to guide you to do the exercises that you need to do. And for the clinicians, please stay updated on the research that is coming out. And also, I think we have our responsibility is, of course, to get the knowledge out there, but also we have to choose the words that we use so that we can ensure these women that moving and movement and exercise is completely safe. And that is regards to not just the diastasis, but also pelvic pain, pelvic girdle pain, pelvic floor issues. It's not dangerous to move. It's very important.
I think we should put a slogan on that. Yes. And just to finalize this lovely conversation, Nina, you talked already about your future steps. Hopefully you get the funding and we can work together and improve knowledge in this area of pelvic pain, diastasis, women's health in general. But just a final message, words of encouragement as you are a girl in science as me. What would you say to fellow women in science?
Just keep up the good work and believe in yourself, and the world really, really needs our research.
Okay. Thank you so much, Nina, for that. And I hope to meet you soon again. We will meet again in Oslo. I'm so happy in March to be with you. Actually, do you want to tell me a bit about what's going to happen in Oslo in March?
Every year, the Norwegian Women's Health Physiotherapy Group arranged this seminar or a conference on women's health. And we all always try to sort of get the newest research presented in a way so that clinicians can take the message away and apply it into their clinical practice the next day. And in July, Kari Bø turned 70 years old, and we have the next year's conference in March in Oslo is dedicated to her work, and we are going to celebrate her contribution to women's health research. We have invited many of her collaborators throughout the years from all over the world. So we have big names like Patrícia Mota, we have Kari Bø, Siv Mørkved, we've got Christina from Brazil, we've got Chantal from Canada, and we've got people coming over from Australia. And we've also got some up-and-coming Norwegian names as well. And it's the topic is quite wide. It's pelvic girdle pain, it's pelvic health, it's perineal tears, it's osteoporosis, but all women's health. And we've got 2 days filled in March 2026. So everyone is welcome to attend, either in person in Oslo, but it will also be possible to attend digitally.
That's amazing opportunity. And thank you so much for including me. I have to confess, I told this to Kari already. It's not about me, it's about you, but I was emotional. So I think it's a beautiful thing that you are preparing, and I am thrilled to participate. I think it's going to be amazing, and I invite everyone to join.
Yes.
Either, as you said, in person or online. It will be, I'm sure, as always, a very rich moment of sharing knowledge and friendship also. So it's really a privilege. I feel very grateful for that. And Nina, if not before, see you in March in Oslo, and I will hug you tight. I have to confess.
Okay, perfect.
Thank you so much.
Thank you.
Okay. Bye-bye.
Bye.
Thank you. Bye. That was Dr. Nina Theodorsen, a brilliant researcher and clinician who is truly empowering women to trust their bodies. I love her core message that our clinical language matters and that we must shift the focus from fear-based restrictions to celebrating what the female body is capable of. Her research is so crucial because it gives us the evidence to finally tell women it's safe to move, to be strong, and to enjoy the feeling of a body that works. This episode of Just Between Us and Science was brought to you by Eleva Care, your digital companion for women's health and recovery. Visit eleva.care to learn more. If you enjoyed today's episode, please follow, rate, and share the podcast. It helps us grow and bring more evidence-based voices into this space. I'm Patrícia Mota, and this was Just Between Us and Science.